All right, good morning, everyone. I'm Frank Jerkowitz. This is Dave Christensen and Steve Maxwell. We're here on behalf of AAAEM regarding the annual benchmark survey and our results specifically over FY23. Just a little bit of background on the benchmark survey. So this is a collaborative effort with the Academic Chairs of Emergency Medicine and then the Academy of Academic Administrators in Emergency Medicine. And you can see our membership is across the nation, so we have representatives from most of the academic ED departments across the U.S. Sorry about that. So kind of a survey timeline that we want to go over. We're going to be focused today on FY23, so that's July 1 of 2022 through June 30 of 2023. We have been running this survey since 2012. But we want to look really at, pre-COVID to today. So this is, when we look at the academic ED, our benchmark is separated out into academic and community sites, but for purpose of this presentation, we're going to be focused on the academic ED. So median hospital beds across our respondents is 604 hospital beds, licensed ED beds 57, and about 537,000 bed hours in total. And then when we look at the treat and release versus admitted patients, you can see the distribution there, about 38,000 treat and release and almost 15,000 admissions, and then hospital observations around 3,000. Total visits just under 64,000 for this group. And when we look at the range of visits in the respondents, there were somewhere between 28,000 and 145,000 visits across all respondents. And we have about 66% unique visits. So patient volume trend, again, this is median over time. We're looking at 2019 through 23. So we have started to see we're rebounded to pre-COVID total numbers. Hospitalizations over this time have been relatively flat, and then we had that dip for discharged patients as COVID hit. I want to move on to inpatient occupancy and how this has an impact on ED operations. That first clock to your left represents midnight. The second one is also midnight, and then the third in red is 7 a.m. So when we look at the first midnight across all departments, about 89% occupancy of inpatient beds at midnight across the respondents. And then we look at a subset of Department of Medicine beds, and they're at about 91% at midnight. Now, if you flip to 7 a.m., you see that the Department of Medicine beds increase to about 94% occupancy at 7 a.m. And why this is important is because about 80% of those patients in those medicine beds come from these academic EDs, and about 67% of our hospitalizations go to a medicine bed. So if you look at some other drivers of operation here, and again, we're just focused on how the inpatient occupancy, specifically in medicine beds, has an impact on wait time and how long patients are being boarded really in the ED. And as the inpatient occupancy increases, we see that the wait time will increase also, and then there's a significant increase and really an inflection point at 7 a.m. when we look specifically again at those Department of Medicine beds. So left before treatment, we have seen an increase in total left before treatment across the years. You see that there is a slight uptick really in FY21 into 22 for both screening and left, and then also total left without being seen. And we look at median length of stay for patients. So the total length of stay in FY23 started to drop off a little bit, and the treat and release, though, patients have increased over time. And then we look at the admitted patients, and that's where you really see the impact again of that occupancy, that we've had a significant increase in length of stay for those admitted patients. And we go to bed to decision time. So this is looking at the decision to admit or discharge and dispoing the patients. And we have seen an increase over the past 3 years of the time to dispo for those admitted patients. The discharge, time to discharge is somewhat flat after we saw that decrease starting in COVID, and has remained below what we saw pre-COVID. And then this is probably what most of you are really interested in is, okay, so how does all this play into boarding and what does that look like over time? So if you look at pre-COVID FY19 where we were, again, there's about nine beds fully dedicated to inpatient care. It started to increase in FY20 as we were experiencing COVID, and then it went from 10 to 13 beds in 21 to 14.4 in 22, and then in 23 we climbed again to 14.5 beds fully dedicated to inpatient care over the time. And then as we look at the boarding distribution, over time again, we have seen a decrease in patients that are boarded less than 4 hours in the ED. Started to see a slight increase with patients 4 to 8 hours. And then where we really see the impact again is on those patients that are boarding greater than 8 hours. You can see over time that has climbed year over year, and more significantly in the last 3 years. So let's look at ancillary resource utilization. So CT utilization from FY19 to FY23 is up. So is MRI utilization. And then we look at also consult and discharge patients. That percent is also up from FY19 to 23. And then probably what's really significant on this slide is the MRI turnaround time. So while in FY19 it was 4 hours and 5.5 hours in FY23, the mean hours actually went from 5 hours versus 11.3 hours on that MRI turnaround time. Okay, I'm going to turn it over now to Dave Christensen, who's going to be sharing some data on faculty salary.
Good morning. I'm Dave Christensen. I'm from the University of Florida in Jacksonville. Frank is my counterpart. He's over in Gainesville. I want to do a quick shout out to Dr. Volturo, who is here looking over this. He is on the benchmark committee as chair representative and has been for many years and is an incredible fund of knowledge and guidance. The data we're going to talk about today is faculty compensation. Some benchmarks, some growth in promotion and tenure, and then we aren't going to cover professional billing, but we will talk about APP salaries too, because that's a source of consideration for a lot of shops. All right. So in terms of faculty demographics, our faculty ranks break out kind of along these lines, about 2% instructor, 51% assistant, 28% associate, and 14% professor. And this will reflect a little bit of a trend that you'll see throughout, where we're seeing an increase in those upper ranks. And that suggests a healthy promotion pipeline, but it's costing us some associate or assistants. You can see that the significant growth has been between the assistant to associate and associate to professor levels. Time in EM, typically for an instructor, is about 3.7 years. In EM for assistant, 6.5, 13 at the associate level, and 21.6 for a full professor. Mean total salary, and this would be total compensation for all EM without chairs, chiefs, and with pure pediatrics removed, has risen to $343,000. This is a fairly healthy incline, particularly in the post-COVID era, where I think you all definitely showed your strengths. Over the last 5 years, you're looking at about a 16% increase on, if you look at that over that period of time, that's better than a 3% increase year over year. Everybody remember the days when we used to joke about a 3% increase? 3% doesn't sound too bad these days. So if mean total comp is 343 and it's up 4.1% over the previous year, what does that look like in terms of base salary? So again, with chairs, chiefs, and pure pediatrics removed, the mean base salary is about 288. And where does that look for historical? So in the instructor ranks, we're kind of leveled out at about 285. Assistant professors at 322, associates at 354, and professor at 393. Now this is total comp again, so I am going back and forth a little bit. The other was to give you a little bit of a baseline. What that reflects over the period of time is a 10% increase in each of those rank jumps for anybody who does actively promote. So it does, it does give some incentive to folks to stay in academic emergency medicine if they can have that kind of a pathway. Clinical productivity. So this hasn't particularly changed in the last several years. We're still seeing about, in our EDs, in the typical academic ED, about 28,000 clinical hours. Patients per hour that are staffed for any particular ED physician is about 2.3. Patients per hour billed, 2.9. Work RVU and per CFTE, about 13,000, which is up on the mean side. But work RVUs per MD hour, and this is sometimes a metric that a lot of folks use, 6.8 up from a median of 6.5. We're also an outfit or a discipline of multiple missions, and what we're finding is a little bit of a trend, and it's a little alarming in terms of our academic footprint. In 2015, we had a 63% clinical footprint, 13% in administration, 16% in education, and 8% in research. Trending up to 2003 or 23, obviously the big winner has, in terms of the attention of our time, has been clinical, with that coming at the expense largely of education and administration. You can understand administration because there's always pressure to cut down on overhead and reduce those things. But the fact that it's coming from our educational activities is a little problem oriented. I'm going to go to the APP salary survey now. Most of our shops do have PAs or NPs in some form or another. We're using them in more locations throughout our EDs than we have in the past. Some still use it strictly as a fast track or as a screening mechanism. Others use it in their main ED, or they use it as some other mechanism. On average, they're doing about 1,600 total hours per year, and a total salary of 141. I have to caveat that because that fluctuates significantly, as does the physician salary data, based on region, and we do have regional breakdowns. I'll talk about that in just a second. There's minimal difference in those numbers, though, between the NP and the PA. I know that different folks in different shops have different preferences for different titles, and some of that is because of the state that you function in and their ability to practice at different levels. So in terms of those that have a leadership responsibility, they may have upwards of a 300-hour reduction for a lead or an administrative APP, or an $18,000 difference between administrative role if they have. And that growth curve that we noted with everyone's salary is also prevalent in the APP salary. So total salary for comp is up 5.5% from the previous year on the APP side as well. This is just got one more, apologize. It also changes based on time in EM. 0 to 1 year, or somebody who's just getting into EM. And these might be folks that are coming straight out of school too, although I think most shops do appreciate somebody having some amount of clinical experience before they come into EM because of its pace. But 0 to 1 years, 2 to 4, 5 to 9, 10 to 14, little dip there at 15 to 19, and then plus 20. But there's been no significant change in the total hours worked or this data in terms of years of service that we've noted over the last couple of years. I want to make a plug for our benchmark committee in that what you've seen here is just a small portion of the data that's available. I did bring examples of our full physician salary survey and our NPP salary survey, and I'll have them up here for you to look at, but not photograph. But if your institution is a member of AAAEM, I mean, that's really what we're about, is to have you become a member, share your data with us, our data becomes your data, and you can use that. We also have publishing and presentation opportunities. We want to partner with folks, and if you have an interest in that, Steve will talk about some of that, and we have representatives here that can talk to you about that as well. Thank you very much, and I'm going to turn this over to Steve Maxwell from the University of Michigan.
So as Dave was saying, there's about 100 different sites that we have their data. That represents about 80 institutions. You don't necessarily have to submit for every domain. So for instance, on the research sites, there's about 45 of the 100 sites that participate in the research area. And you can see that we've had steady growth in the number of submissions over the years, as well as in the funding. I'd like to point out at the top level of the yellow line, the NIH funding of $107 million. That represents about 80% of the Blue Ridge NIH funding. So we're capturing about 80% of the funding within the specialty. When we look at sites, what we've started to see is the number of sites that have more than $5 million of funded research has increased by about 3 sites over the last 2 years. And we've also seen a progression of sites above $15 million and above $20 million. So we're seeing more research done in the specialty and more research across more sites. The grant success typically runs about 40%. So 40% of the grants you submit are eventually funded. We've noticed that that stays consistent regardless of whether it's a junior investigator or a more senior investigator, and whether your site is submitting more grants or less grants. We've also noticed that there are more grants when there are more PIs. So the more people you have, the more grants that you have. There also is a correlation between total publications and your number of grants and the amount of grant spending. So as you invest in doing research, your number of publications go up, your number of grants go up. And it is a pipeline that costs money to invest in. So we've seen steady investment in the number of K awardees across the specialty, and within the sites we see growth in the sites that only have 1 K awardee. So more sites are investing in more people with Ks. And what we've started to notice is, as the specialty has created goals, as the chairs have created goals for the number of grants, the number of investigators, the number of departments that are investing and having research, that we are now exceeding the goals for the 2030 targets for the NIH funding, for the number of projects, and we're getting close in the number of principal investigators and departments. And so those are our slides, and we are open for questions. Yes, sir. So you should reach out to your administrator or your chair, and they can connect you to someone from the benchmark survey, and we can get you set up with a user ID to the Insights portal. You want? Oh,
Hi, reach out to me.
yes, sir.
You don't have a regional graphic or something that distributes where your members are from?
We do have that slide. It's not, I think, in this deck. It's about a quarter for each of the 4 regions, so east, north, north central, south central, and west. Maybe slightly more to the east. Yes, sir.
What, if any, interface do you have with the EDA? And I'm curious if there's direct head-to-head comparison as far as a lot of these key things, are they aligned in what we're looking at in this benchmark and versus?
Do you want to?
Hello? Okay. So we are in touch with the EDBA. We recognize that their scope is quite a bit larger because they take all EDs, not just academic. And while we do start to sample EDs within an academic health system that are affiliated or a community-based affiliate, theirs is far out there. I mean, their reach is quite a bit less discriminative. That's not a bad thing. They're also a lot more geared towards operational metrics. They have left, I think, the salary and compensation and lifestyle stuff to either the MGMA or in academics, that would be us. But we are in ongoing conversations with them. In fact, the chairman of our benchmark committee, Greg Archerall, who's going to be leading one of these in a minute, can also speak to that. We've talked to them for a number of years, and we're on very good terms. We look for opportunities to work with them. There's probably opportunities for us to cross-validate data on certain things.
Yes, sir.
So a lot of these measures have been around for a really long time. We sort of tried to use the left before treatment complete as a new English measure, left not being seen, probably the varying degrees of accuracy. But have you thought about looking at other measures as well that might give a look at our situations with a slightly different lens, maybe employ some overlap. So one that we use is hours of care, and that might smooth out some of the differences between organizations. For instance, hours of care for discharge patients. Who's a discharge patient? It might be a sprained ankle that's really quick, or it might be someone who gets 5 consults, would have been admitted 2 years ago, and spent 18 hours in the emergency department, now in observation, and then was discharged. Or hours of care for providers who have all these patients that are boarded, they're on the ED service. That's not compensated care. It might be different. It might be a little different than the boarding.
One of the nice things with the Insights portal is that you can create a cohort of institutions to benchmark yourself against relative to each of the indicators within the data set. So you could say for an institution that has boarding of greater than 25,000 hours and has an admission rate of 25%, let me compare myself on these metrics. So that then starts to be able to refine you relative to the whole data set. And then you can find those indicators that for your type of the facility that has your type of patient population, because we're all slightly different.
Sure. Plus, but I mean, not to interrupt you, but for instance, with boarding, you're counting the time that the patient is admitted. That definition varies from place to place, even with the same timestamp. You might have to make 15 phone calls and argue with 3 different services before that patient is technically a boarder, whereas in another institution, doctors writes an order in Epic or Cerner or whatever, and they're now counted as a boarder.
Yes.
So there are differences.
Willie, the database is incredibly even more detailed than the EDBA. There is information in terms of levels of service timestamps in terms of where the patient is through the process, billing numbers, RVUs. There's a tremendous amount of data in there that can be mixed and matched. The next thing that Greg is going to be talking about is getting exactly to where you're going, is how do different EDs vary, right? And in terms of their complexity, because everyone thinks, we're an academic ED, we have, more sick patients as compared to the community hospital down the street. And in some respects, it's true, but to be able to compare to another academic ED is one of the projects that we've been working on now for, I don't know, probably 5-6 years, right? And with Vizient. And we've come up with a tool that, after going through about 10,000 visits in Vizient, to get some metrics where we could start to do that. Because, to your point, there's a lot of variability in terms, right? In Massachusetts, it's 2 hours before you're a boarder. In reality, you're a boarder from the time I tell you that you're admitted. So there's more to come on this, and this is the advantage of the database, but it's tremendously powerful database. Thanks.
Question?
Dave Snyder from Las Vegas, and I don't want to speak for the gentleman over there, but I think part of that question is, how nimble is this database? And is there a process for changing metrics going forward? Is there a process within this group to bring forward ideas of different metrics that maybe we're not reflecting currently as we go forward?
So, yeah, I'll jump in on this one. Every year, the benchmark committee meets in the middle of the summer, not the middle of this year, it's in June, but, and we're going to Milwaukee. But no, it'll be wonderful. And we get together and we talk about not only are we getting what we need, but what are some new things? What's run its course? What hasn't moved the needle for any period of time? It's not changing. It's set science. What else would we be looking for? And we're always interested in those things. The other thing about the nimbleness of this product or this website, about 6 years ago, with the help and support of the chairs and Dr. Volturo, we moved our data from spreadsheet orientation to a hosted statistical company, which was Roundtable Analytics. It is now Huron Analytics. It gave us a website now where you can cross-utilize and look for different correlations. So you can look for, okay, what's the relationship between this and that? And so it does have that degree of investigative capability. But stick around for the complexity index talk, because that's going to be a good one too.
Thanks very much. Appreciate it, everyone.